All right, Rodrigo. I know we talked a little bit before, but still, since my main audience is in Asia, can you like introduce yourself a little bit?
Sure, yeah. Thanks for having me. It's a pleasure. I'm a physical therapist. I was born and raised in Brazil. I'm specialized in sports physical therapy. I did my master's and my PhD in physical therapy. And during my PhD, I was fortunate to go to Australia. I was almost a year in Canberra in Australia doing my PhD with Professor Craig Purdon at the Australian Institute of Sport. It was a fantastic experience. Craig is he's been involved in tendinopathy research since the 80s. He's been involved in 5 Olympic Games. He's such a legend in tendinopathy. So it was a great experience. Then I went to the US. I did a postdoc with Professor Karen Subernagel at the University of Delaware. It was a fantastic experience as well. I got to see how she manages her lab, how she handles research in general. It was a really, really incredible experience. More recently, I went to Copenhagen as well. I have some collaborations in Denmark. I spent some months there in Copenhagen, working with Peter Magnuson and Michael Kerr. And now I'm living in the northeast coast of Brazil. I'm an associate professor here at a university in the coast in a city called Natal. I teach sports physical therapy. I supervise the students in their clinical rotations in their last year of physical therapy school. And I also supervise master's degree and PhD students. I'm the PI of a research group called the Brazilian Tendinopathy and Sports Injuries Research Group. So yeah, I've been learning from some of the best, and now I'm fortunate to do research and have collaborations all over the world. And I'm looking forward to our conversation.
Nice, nice. So, first of all, like what spikes your interest into tendon?
Well, it's a very complex injury. When I was in school, when I was in physical therapy school, what they used to teach us it was that it was an inflammatory condition. You should just do some ice, rest, anti-inflammatory medications, and then gradually stretch and do some exercises, and then people will get better and go back to doing what they want to do. And then trying to apply that, we saw that it got us nowhere. It may work for a little while. It gives you a little bit of results in the short term, but as soon as they go back to loading really heavily, doing their heavy sports activities, or even sometimes just their everyday activities, they just get worse again. So it doesn't really work. And then the eccentrics were really popular when I was right after PT school. So the Alfredson's eccentric program was the new trendy thing. Everybody was doing that. So I started to apply that in clinical practice. I started to see some interesting results, but it was very variable. It was like some people would really flare up after doing that because it's a very high load exercise. Now we know that, but we didn't know that at the time. But it did work for several people, so it was promising. It was something that it was interesting to try to apply. But it's very cool to be able to see how much the research has evolved in the last 15, 20 years, because we can see how much now we know about how much load is being applied to the tendons, how much the tendon tolerates in terms of different kinds of loads. Now we have loading programs that are much more comprehensive in terms of phases, isometric, heavy, slow resistance, biometrics, sports specific exercises. So it was good to be a part of the process. And then trying to understand a little bit more, I started to do a PhD on the topic, and we started to see the influences of the kinetic chain in the tendons. So we were studying patellar tendinopathy people, and I was looking into hips and ankles, their landing mechanics, trying to understand what caused the overload in the first place, instead of just doing a loading program for the knee. So it was just fascinating stuff. I just kept studying more and more, and that's what got me into it.
Nice. I love it. I love it. So, I guess this is what I want to ask because like you kind of mentioned and like I kind of said, like every time when it comes to tendinopathy, tendon pain, whatsoever, everybody's doing like, all right, isometric or slow heavy eccentric. Well, sometimes it works, sometimes it doesn't. And I do feel like super focus on the pain side sometimes is not really helpful. So maybe can you like explain a little bit more like your process of like uh approaching a tendon pain? Like how would you assess it? Let's start with patellar tendon. Like what would you be looking into? And like when it comes to rehab, is it like the Joe Cook four-stage rehab? Can you kind of like explain a little bit your approach?
Sure. Yeah. For patellar tendon, what we do is we do it a four-stage approach, but we do an adaptation of what they're doing. We published a paper of a PhD student of mine where we're doing the four-stage rehab, but what we're doing is in the first stage, stage one, what we typically do is we do isometrics if the patient doesn't tolerate isotonics. So it's very common for you to try to do a squat or a leg press exercise or a knee extension, and they're very, very sensitive. So if they don't tolerate the isotonics because it's too painful for them, what we would do is we would do isometrics. I would try the analgesic isometrics, which would be the long duration, 30 to 45 seconds, 5 sets of that. If it's analgesic for them, if we see an immediate decrease in pain, fantastic. I would use that all the time. If not, it's always still a good a way of starting to load the tendon. So we do isometric if they can't tolerate the isotonic. But we also focus a lot on decreasing their overload in their first stage. So we do a lot of focus on their ankle and on their hips. So we do mobilizations to improve dorsiflexion range of motion because we know that that's a risk factor for patellar tendinopathy. We strengthen their soleus. We do a lot of exercise for the gluteus maximus because it's an important synergist of the quadriceps. So if the glutes, we saw that in my PhD, we saw that people with patellar tendinopathy had 27% less strength in their hip extensors. So that's also something that we focus on stage one. And I also do a lot of loading for the other side, the contralateral leg, for two reasons. The first reason is because people with patellar tendinopathy very often have pathology on the other side, even though they don't have pain. It's very, very common for them to have an asymptomatic pathology on the other side. So I need to load the other side. Otherwise, when I'm doing heavy plyometrics in the end, it's very likely that they will become symptomatic as well. They can rupture too, because if they have a silent pathology, ruptures occur when that happens. So I do a heavy program for the other side. And the second reason why I do that is because of something called the cross education effect. When you do an exercise for one leg, there's a lot of studies showing that you have a gain in strength in the other side, in the opposite side. It can be as high as 20% increase in strength just by doing a very heavy exercise in one side. You gain strength in the other side. Maybe it's because of activation in the spine, something in hormones. We're not sure why that happens, but that's also something that I work with in the initial stage. So heavy loading for the contralateral side, soleus, gluteus maximus, dorsiflexion range of motion. And if they're still training, we work on their landing mechanics because I want their landing mechanics to be soft. I don't want them to land very, very stiff, as it's very common to see in patellar tendinopathy. So I try to teach them variability of movement. I want them to land using the three joints of the lower limb, the hips, the knee, and the ankle, not just landing using just the knee with the trunk very upright. That way, we try to decrease the excessive load in their patellar tendons so that they settle down a little bit. And we also try to do load management with education. So ideally, I have them not training every day, at least one day of rest, trying to keep them training, but with a load that doesn't flare up too much in the next day. So sometimes it's just one set. They can't play the whole thing. Sometimes we decrease the number of jumps because we want them to settle down in stage one. As soon as they start to tolerate the loading in their symptomatic side, we start the phase two, which would be isotonic loading, basically the heavy slow resistance protocol. We do 3 exercises for the quads slowly, so 3 seconds down, 3 seconds up. We do a lot of focus on eccentric and concentric contractions with 3 exercises alternate day, so typically Monday, Wednesday, and Friday. And that way we progress their low tolerance in their quads and their patellar tendon. We typically do that protocol from Mads Konsgaard from Denmark. So we start with 15 repetition maximum, and we gradually build low tolerance until we get to 6 repetition maximum. That's typically what I do in phase two. And I also progress on the training for the kinetic chain. So more loads for the soleus, for the glute max, We do a lot of exercise single limb now. So in the initial stage, I do a lot of bilateral work for the soleus and for the glutes. Phase two, typically I focus on unilateral exercises for the soleus and for the glutes. So I'm progressing the work for those joints as well, for those muscles as well. Then as soon as they get to a stage where they can tolerate high velocity, we progress to plyometrics. So we do plyometric exercises for their knees, typically bilateral jumps, several variations of jumps. That would be drop jumps, drop vertical jumps. We do split squat jumps, large variety of jumps. And it has to be sport specific. So we try to tailor the phase three and phase four to building the load tolerance that they have to be able to endure for their specific sport. So we do, if it's a volleyball player, it has to be vertical jumps and also horizontal jumps because they have to get close to the net. If it's basketball, it has to have change of direction, deceleration. We have to do as much sport specific as possible. And phase four will be as much sport specific activities in the court, trying to simulate what they're going to actually face when they come back to their sport. That way, we gradually build their load tolerance until they can come back to doing what they want to do.
Nice, nice. So, all right, my question would be, what what if at the beginning of isometric phase, like when you do isometric, it actually make the pain worse?
Yeah, sometimes that happens. We try to change the isometric sometimes, change the angle. Sometimes we change the exercise. If they don't tolerate the knee extension, you can do a closed kinetic chain isometric. It can be a leg press. It can be a Spanish squat. We do a lot of electrical stem when they don't tolerate the isometrics well. So we do neuromuscular electrical stimulation to their quads. That helps a lot with the pain and at the same time increases the activation of the muscle, which is typically inhibited because of their pain. That also helps a lot. So that's some of the things that we do. And sometimes they don't even tolerate that. So sometimes what we would do would be the Berlin method. The group from Berlin does slow, short duration contractions. So they would be 3 seconds contraction instead of the long duration contractions for analgesia. That's also an option for phase one if they're not tolerating the long duration contractions. But typically, with one of those approaches, you can have a good response with these patients.
Mm. And for assessing tendon, like you mentioned, sometimes even with the tendon pathology is not like fully healthy, it's- they might not have symptoms. So
The
how,
other side, you mean, right?
yeah, so
Uh,
like, so how do you determine like are you gonna change your approach with the pathology or not?
for the other side, you mean?
Yeah.
Well, I guess it depends on how much I'm worried about the other tendon rupturing or not, and how high the activity of their that they have to go back to doing early. And if it's an athlete that has to keep jumping a lot, and I know from the imaging that they have a very pathological contralateral side, I would back off of really heavy activities, very heavy jumping for a while until I can build low tolerance in the other side as well. Because with the asymptomatic side that has a very strong, very large pathology, I'm very concerned about ruptures. That's where you see the ruptures happening. So if you look at them landing single leg with their trunk really upright and do a very deep knee flexion landing, it has a very high chance of a rupture if they don't have pain to protect them, but they have a very large pathology in their tendon. So if it's a big pathology in imaging, no pain, the other side is painful, I would try to back off from really high level activities, very high jumps in the beginning until I build low tolerance in the other side as well. Typically, that takes about 6 weeks, 7 weeks to actually have a tendon that is stiff, has a good low tolerance, and then you can go back to gradually go back to doing the high velocity activities again.
Hmm. Uh, what about Achilles tendon? So especially like everybody's talking about like uh this false step mechanism.
Yep.
So um I know some researchers say like you can tear the Achilles tendon even when it's fully healthy, but some say it's not the case. What are your thoughts?
Well, the majority of ruptures will be with pathology. If you look into the studies, like sometimes you see studies showing that 95% of Achilles tendons that would rupture had some degree of pathology. Then that's what we see typically. So you look at them in the OR, in the surgery, in the surgical room, and you look into the tendon. It's very friable. It's very degenerative tendon. It's it's not a healthy tendon at all. The vast majority of cases, you can have ruptures occurring in healthy tendons when they are subjected to some medications that can happen too. So when they're using corticosteroids, when they're using anabolic steroids, when they're using fluoroquinolones, the antibiotic, those have a negative impact on tendons. Sometimes statins, medication for cholesterol, can also have a negative effect on tendons. So sometimes that would happen too. But the large majority of what we see is ruptures occurring in people who didn't have any pain but had a very large pathology in their tendon.
So instead of blaming on false step, maybe we should dive deep into the pathology.
I think so. Yeah, I think we should be imaging them, especially in the high level teams. If ultrasound is relatively cheap in comparison to other imaging technologies, so it doesn't cost that much for you to get them to do an ultrasound in the preseason, both Achilles, both patellar tendons, if they're jumping athletes, if they're athletes that have a high risk of rupture, you should be imaging them because there's very strong literature showing us that they have a higher risk of developing tendinopathy if they have a pathology in the preseason and they start training really heavily, and they also have a very high risk of rupture. So yeah, I believe that we should be imaging them. And as soon as we see that, we should be doing more load management with these people. We should be addressing their kinetic chain, and we should be doing a loading program to prevent that rupture from occurring. Because of course, the step back is the typical Achilles rupture mechanism, but how the hell are you going to tell an athlete not to do that? That's their typical step back to go forward. You can't play basketball without stepping back. You can't play any sport that involves change of direction without stepping back. So you can't take the injury mechanism away from the sport. So what you have to do is you have to make sure that you cover all the known risk factors as well as you can to prevent the rupture and to make sure that the athlete is able to tolerate the loads that they're going to be subjected to their specific sport.
Nice, nice. And I guess if false step is not the thing we really need to worry about, and you mentioned like the kinetic chain, so what else do we need to like look into?
Well, I guess you have to be looking into the muscles that are more likely involved more directly involved with their sport. I mean, in my mind, it makes no sense for you to just focus on one or two muscle groups and just train those and then hope for the best. I mean, if you know that for a very high jumper, you need to have strong calves, strong quads, and strong glutes, otherwise you can't jump high. How the hell are you not working on those muscles? I mean, it doesn't really make that much sense to me. We see a lot of people with very significant deficits in their strength in their proximal or distal muscles after they have pain. Sometimes it's not the risk factor. If you look into studies that are prospective studies, they don't really see that weakness as being a risk factor, but we very often see after they have pain, they have weakness on those muscles. And then my problem with just doing squats, for instance, although I really love squats, I get my patients to do squats all the time. If you do a multi-joint exercise and they have a lot of inhibition because of their pain, they're going to shift the load away from the joints. They're not going to load as much as we need them to load their joints, their muscles from the different areas. So in my mind, we really need to have at least one single joint exercise for the hips, for the knee, and for the ankle, so that you can't compensate. You can't shy away from that exercise. You need to really load those specific muscles individually, as well as collectively in multi-joint exercises. But in my mind, it makes no sense for you to not be doing calf raises, gluteus maximus exercises, and quad exercises for people who jump and run at high velocities, change direction, because those muscle groups are key, are absolutely necessary for them to perform at a high level and to be healthy in their lower limb joints. So that's basically what we need to focus on my mind in terms of prevention, if we can, and also for rehab. We see very often a lot of people just focusing on the pathology and just in the specific area that is painful and forgetting about the whole rest. Sometimes they think it's obvious. Oh, you just, of course, you're going to do exercises for everything else. No, that's not as obvious. A lot of people would just focus on their program that you gave them, which would be just the quads exercises, and they forget about the rest. So you need to be very specific about what you need them to do, specific in terms of not being too many exercises as well, because if you give them 15 exercises, they're not going to do it. It doesn't really matter. So it has to be specific, it has to be objective, few exercises, but the exercises that are actually addressing the main muscles that they need.
Mm. So, uh, I was listening to the podcast Joe Cook did with Jake Tura, and said a lot of times, when it comes to patella tendinopathy, they might have like a relatively weaker calf.
Yeah.
What about Achilles tendinopathy?
Well, it's common for them to have quadriceps weakness and gluteal weakness. I can give you the studies. One study from my good friend Igor Sancho from Spain saw that people with Achilles tendinopathy have weak quads and weak gluteus muscles as well. Not only the calf is weak. There's another study from a guy called Habits that saw that people with Achilles tendinopathy have approximately 28 to 32% less strength in their gluteus maximus and gluteus medius as well. So yeah, those proximal muscles are weak as well in these people. And if you think that for running, for jumping, you need the calf, the quads, and the glutes to work collectively so that you have performance, so that you have an efficient load dissipation strategy, you have to have an attention to those muscles as well. So we shouldn't, absolutely, we shouldn't be just looking into the joint that is affected. So for Achilles tendinopathy, you should be loading the quads and the glutes. For patellar tendinopathy, you should be loading the glutes and the calf as well, because that's the way you reduce the overuse in the joint. And you also get analgesic effects from exercise in general. We have the effect of hypoalgesia induced by exercise. So they get better in their pain just by exercising areas that are distant from their pain, which is also great. And at the same time, we're making their kinetic chain robust so that it can properly deal with the forces that I'm going to need in their phase 3 and phase 4 when they're jumping and doing sport specific exercises.
Nice, nice. I love it. So, uh, talk to me about what if at the let's say at the beginning of rehab the tendinopathy, and anything you do just hurts and there's just sharp pain. What would you do at the beginning?
So that's when you focus on the other limb. That's when you do really heavy load for the other side. That's when you do calf work because the knee hurts too much. So if I'm sitting down and I'm doing seated calf raises, they're not going to have pain because their pain is in their quads, if in their patellar tendon. That's when I do single limb exercises for the glutes because it hurts too much to do exercise for their knee. So that's what it's really interesting. That's because you're doing exercise. You're getting them better through analgesic effects of exercise in general, and you're preparing their kinetic chain. It makes sense to them when you explain to them why you're doing that. You're saying they're saying, "Oh, my knee hurts." Yeah, but we're preparing your whole body to go back to what you need to do. And every time I try to do isometrics as well. If isometrics are too painful, electrical stem helps a lot. If even that is too painful to keep a long duration contraction, we do a short duration contraction. Typically, one of these things will help. So that's how I handle these cases where they're too symptomatic in the initial stage. But
Nice.
what I would What I would absolutely not do is what we used to do in the last decade, which would be give them eccentric exercises in day one. We we did a study where we measured the patellar tendon load in 25 different exercises that load the quadriceps. That's what I did in my postdoc with Karin Subernagel in collaboration with Professor Josh Baxter at the University of Pennsylvania. So we measured the loads in their patellar tendon during a very different variation of exercises for their quads, jumps, single limb jumps, Spanish squat, Bulgarian squat, single limb, double limb, hopping forward, repeated hopping forward, side hops. We did 35 different exercises. And what we found was that out of all these exercises, the single leg decline squats, the eccentric exercise that we used to do in their decline board, that's the exercise that gives the highest intensity of load in their patellar tendon. If you compare to all the jumps, running deceleration, nothing loads the patellar tendon more than the single leg decline squat. And that's why it's so painful for them to do that in the first phase. It's a very, very high load exercise. If you want to put that in your rehab, in my mind, you should be doing that in the final stages of rehab. If you want to get them really ready to go back to tolerating really heavy loads, if our basic premise is gradually building a load tolerance, it doesn't make any sense for you to start with the first exercise being the exercise with the highest load. So we shifted away from doing really heavy eccentrics in the beginning because, like you said, very often they are very symptomatic in the beginning. And now the only time I would see eccentrics being really useful would be in the final stages of rehab before I let them go back to doing sport specific exercises that are really high load for the tendon.
So, well, what about like needling for the tendon or needle the tendon or BFR for a tendinopathy? Because I get I'm not a therapist, but like I work with athletes, so I get like
Yeah.
extreme like results on both sides. Like some athletes will respond okay with needle and a tendon. Some athletes just absolute hate it.
Yeah, I'm not a fan of needling in general. I don't like needling tendons. When we see tendons being biopsied, we see a lot of really significant alterations in their tendons after the needling. Unless you've tried everything else and nothing worked, and you've done a really good loading program, you're completely out of choices. I wouldn't consider anything invasive that involves poking the tendon. If you want to do needling for the muscle, that's fine. I mean, I see a lot of people doing dry needling for the muscle to try to decrease their
So
really
Tom,
sensitive. Some people have a lot of really sensitive points, sensitive tender points in their muscles. That's fine. But needling the tendon is not something that I would consider a good idea at all. I really don't like that. BFR, it's something that seems promising for joint conditions. So I really like to think about that as an alternative for people who have a patellofemoral pain and have a lot of pain with loading in general. And you want to give them a good stimulus for their muscles to get strong, but you don't want to load their joint too much. So for patellofemoral pain, I think it makes a lot of sense. And there's a very interesting study that saw a good result for uh, lateral elbow tendinopathy using BFR. And they did BFR in their proximal humerus here, and they did exercises for their extensor tendons for their elbow. For the elbow, I think it's a good alternative, a good option because the upper limb tendons, the positional tendons, they respond well to lower loads. I don't like the idea of doing that for tendinopathy in the lower limb though, because if you look at the literature, you will see that exercises need to have a high load in order to induce alterations, adaptations in the lower limb tendons. So if you look into the literature for patellar and Achilles specifically, uh, mostly from the German group, the Adam Munch's, Adam Patz's group, they show that if you do an exercise that is very low load, you get adaptations in the muscles, but you don't get adaptations in the tendon. The tendon doesn't get stiff. It doesn't get uh, it doesn't improve its stiffness. It doesn't become stronger in terms of structure. So for me, it's very counterproductive to have a stimulus that would be good for the muscle to get stronger using BFR for the quads, but the tendon is not following, it's not getting stronger, it's not getting stiffer. So if I can help it, I wouldn't use it for tendinopathy. I would think about using that for joint conditions like patellofemoral pain, like I mentioned. But for tendinopathy, I would prefer to use the other alternatives that I mentioned to you.
All right, this is an interesting part. So patellar tendinopathy and patellofemoral pain, they're both anterior knee pain. And I
Yeah.
do feel like a lot of times, like the diagnosis is not 100% accurate. So talk to me about like like how do you separate these two?
Yeah, that's a very good question because when I was in school too, it wasn't uncommon for studies to just have the umbrella name of anterior knee pain. They would include everybody saying that it's anterior knee pain. And then when you look at them individually, you can see there are dozens of causes for anterior knee pain. You can have a Osgood-Schlatter syndrome. You can have a synovial plica. You can have a meniscus. You can have patellar tendinopathy, quadriceps tendinopathy, patellofemoral pain, referred pain from the hip, referred pain from the lower back. There are dozens of causes for anterior knee pain. So there's no way that we're going to do the same treatment for everybody. We need to have a differential diagnosis that is accurate so that we can have a better treatment. Same thing for the Achilles. I could give you dozens of causes for Achilles tendon pain, for posterior ankle pain, and you can't treat everybody the same. So you need to have a very specific diagnosis, and we have to try to narrow it down as best as we can so that we can do the best treatment approach for our patient. So how do we differentiate patellar tendinopathy and patellofemoral pain? The location of pain matters a lot. So if you have a patellar tendinopathy, and that I learned from Jill Cook. Actually, I was there with her for a long time in Australia, and she's been saying there for a long time. Patellar tendinopathy, the pain is very localized. So typically, what she says, and it's what I see in practice too, people will use just one finger, two fingers at the most, to point where their pain is. So if our patient is pointing to their knee like this, they're pointing two fingers, very localized pain in the patella or in the body of the tendon or in the insertion of the tendon in the tibial tuberosity, patellar tendinopathy is more likely. If you have a very diffuse pain, if they're using their whole hand to show their pain location, if they're saying it's a very diffuse pain when they're loading their knees, think about something else. It can be patellofemoral pain, it can be the Hoffa pad that can be sensitized. Several different things cause diffuse pain. Patellar tendinopathy tends to be very localized. So if you have a jumper athlete, somebody who jumps a lot and is presenting with a very localized tendon pain, most likely it's a patellar tendinopathy. If you have a female who's a runner who has a very diffuse pain in their anterior knee, think about patellofemoral pain. So that's usually what we use to differentiate the two.
Hmm. And so if we how can we load how like what's the rehab process for patellofemoral pain?
Yeah, that's a little different because we want to progressively increase the load tolerance for the cartilage now, for the joint, the patellofemoral joint, not the patellar tendon anymore. So what we see in their guidelines, patellofemoral pain rehab looks like you have to settle down in the beginning. So in the beginning, most likely it's an overuse condition that they're doing too much too soon. They're not used to doing their activity. They just started doing something for weight loss, or they just started running because they want to run a marathon, and they're not doing a progressive, uh, a very good progression in terms of their miles in their weeks. Very common that they will develop something in terms of an overuse condition for their ankle, for their foot, for their shins, or for their knees. And for the knees, what's very common for us to see is a patellofemoral pain. And what we see in guidelines is we have to settle down in the beginning. So it's also useful to strengthen the hip muscles. You see that in guidelines too. The recommendation for patellofemoral pain rehab is quadriceps exercises, most important thing. Gluteus exercises, so hip muscles exercises, are also very useful. Sometimes foot orthoses are helpful too. because they will. There are several mechanisms, but what we believe that it does, it helps us decrease the excessive load in the patellofemoral joint too. Very helpful in some cases, not so helpful in others. We do a lot of taping from the patellofemoral joint, so there's good evidence for that too. We do something is called the McConnell taping, which is taping. It's a rigid tape that helps us increase the contact area of the patella with the femur. And if you think that stress in the joint is force divided by contact area, if you increase the contact area, you decrease the stress. So that's something that we do too. We do taping for the patella. Sometimes I use a brace. I just like to use a like a knee sleeve that is like kind of tight that will increase their contact area. That all those things you help decreasing their pain in the beginning, and we start focusing on their hips in the beginning so that the knee settles down a little bit, and then we gradually start loading their quads in the following weeks. We usually start loading the quads with a joint range of motion that is of comfort to them. So I don't really do the whole open kinetic chain exercise with them because that's too painful. We typically do it from 90 to 45 degrees. It's a shorter range of motion because that way you have a lower load in the patellofemoral joint. So we can load the quadriceps, but not loading the joint too much. We do BFR because BFR will give us a good stimulus for the quads, not loading the joint too much. All of that helps in the initial stages. As soon as they're settling down in terms of pain, you can just progress with a loading program for the quads, the glutes, and then activities that are preparing them to go back to what they want to do. So if they're runners, you have to do exercises that will prepare them for running. If they're your sedentary everyday person, you just do exercises that will prepare them to go up and down stairs and do everyday activities. So that's basically what we do for patellofemoral pain. So as you can see, it's different than patellar tendinopathy. It's not the same thing. That's why it's so important for you to actually do a thorough assessment, to do a differential diagnosis, and then you can treat them properly.
Hmm. So, uh, let's talk about assessment a little bit. So outside of the pain region, patellar tendon will be like very specific and patellofemoral is more vague. Is there any other like way to like separate these two?
Well, in the case of patellar tendon, imaging can help you a little bit too, because it's very common for them to have pain and have imaging abnormalities in your ultrasound. So if you're looking into a young athlete that is jumping a lot and they have when you do imaging, you see a thick patellar tendon. You look at that. They have hypoechoic areas. It's a little darker in their tendon. You look into their location of pain. It's very localized. You're looking into a patellar tendinopathy. Whereas if you have an older person, like a 60, 55-year-old woman that has very diffuse pain in their anterior knee region, it's not patellar tendinopathy at all. So you have to look into the profile of the patient, what they're doing, what loads they're doing in their tendons, in their joints, what's the location of their pain, and that helps you narrow down a little bit more. So you have a few studies that are actually kind of funny because they talk about patellar tendinopathy prevalence in community dwelling women, elderly women, and then there's no way that's patellar tendinopathy, and because patellar tendinopathy happens in people who jump a lot, very high ballistic movements for the knee. It doesn't affect old people who just go up and down stairs. But if you do imaging in 100 people and they are 50 plus years, you're going to see tendon alterations in a lot of people, but their tendon doesn't hurt. So it doesn't make any sense for you to call that patellar tendinopathy. Patellar tendinopathy would be you have imaging alterations very often, but you also have a younger person who's jumping a lot, who's doing a lot of ballistic movements for the knee. Their pain is very localized in the tendon. That's what helps us close the diagnosis.
Hmm. So, I want to backtrack a little bit. When we talk early on, when we talk about patellar tendon, uh, and we kind of say like sometimes on the other side, the pathology maybe is not as healthy out as we think it would be, but it doesn't have symptom. Why is that? Why is that the case?
That's a great question. We have no idea. That's what's beautiful about it because I've been going to the World Tendinopathy events that happen every 2 years. I've been going to that for over 10 years. So 2014 was the first time I went to the conference in Oxford. Then 2016 was in Cape Town in South Africa. Then 2018 in the Netherlands. Then it was in Spain. Every 2 years, the specialists they gather to discuss tendon-related issues. So it's the International Tendinopathy Symposium. And every time we go into those events, the biggest experts in the world are discussing, and we haven't come to a conclusion and to why some people have pain and some people don't. We don't know. And as soon as we figure that out, we're going to be able to prevent injuries a lot better because we're going to understand why some people develop overuse and develop pain, and the other people just develop overuse, develop pathology, but don't develop pain. These guys are the guys that are going to rupture. That we call that silent pathology. They have a very deep, large pathology in their tendons, no pain whatsoever. And then you look into their other side, similar tendon, very large pathology, but very painful. Why the hell the same person has similar structure in both sides, and one side is painful, the other side isn't? We have no idea. We don't really know up until now what causes the pain. We have several hypotheses. There was the inflammatory hypothesis, then there was the mechanical loading hypothesis, the iceberg theory. There are several different theories. What we believe now happens is you have some substances are produced by the tenocytes when they're overloaded. They can produce glutamate, they can produce substance P, which are very nociceptive. They can produce a lot of pain when they're produced, but we have no idea why in one side they would produce that, and the other side they wouldn't. So very often you see people doing symmetrical sports, running. They're loading both sides the same way. One side has pathology, the other side has pathology. One side has pain, the other side doesn't have pain. We don't know. That's the next step. That's the next research question that we have to focus on so that we can learn to prevent these injuries a little bit more.
All right, great. So, uh, I think in the past few years, we talk a lot about load management because, like, tendon don't like huge spike of load. So, from a rehab standpoint, let's say we're talking about elite basketball player. In terms of load management, like return to play, what would be your progression?
You're talking about someone who is being rehabbing a patellar tendinopathy, for example,
Yeah,
and has to
yeah,
go back.
yeah,
Yeah,
yeah.
that's very challenging. I mean, ideally, we would rehab them in the off season. That's what we would ideally do, because in season management is just you have to put out fires. You have to make sure that the guy is performing at its best. People can play with tendinopathy, so they just keep pushing through their pain. So you're trying to manage as best as you can when they're in season. You're trying to give them a little bit of rest after the day that they jumped hundreds of times. You give them isometrics. You give them a little bit of heavy slow resistance in their weeks so that they're building low tolerance in their tendon. And then you gradually improve their low tolerance to jumping until they go back to full sports participation. But when they're in season, there's not that much that you can do in terms of load management because their coaches, their trainers, everybody's trying to work together to make sure that they're available to perform at their best when they have to be in court. So you can't really say to this guy, no, you're not going to train. No, you're not going to, you have to sit in the sidelines. When you're in season, you're just putting out fires. But ideally, as soon as the season's over, you have a really good structured program. Typically, it takes 12 weeks for you to have a very good program that will solve the problem more definitively. But like I said, in season, there's not really that much that you can do in terms of load management to solve the problem definitively. You can just do your best and try to keep them performing as well as they can.
Nice, nice, nice. So I guess that's all the question I have for today. So for those who are interested in what we're talking about today, where can they find you and where can they find those research?
Yeah, sure. I'm on Twitter. I am on Instagram. You can find me there. I have a YouTube channel too, but mostly what you will see is me posting contents in Portuguese because what we try to do is we try to do knowledge translation here in Brazil. But the good thing about technology nowadays is that Instagram, YouTube, they translate everything nowadays. If you just hit translate, they just translate everything to English. So you can find me there. You can just, if you look for my name, Rodrigo Scattone, and Instagram, YouTube, Twitter, you will find me. And that's where we try to share everything that we produce in terms of new research. And that's where I try to do knowledge translation as well. So that's where you can find me.
Nice, nice, nice.